A major lesson that appeared fairly early in the pandemic is that COVID-19 has astonishingly strong risk stratification. If you look at the age distribution of deaths in a country like Austria, for example, we have about 1/10 of the deaths occurring in people who are less than 70 years old. The vast majority of deaths are in people who are old. If you look at the stratification of the risk of fatality for a person who is 80 years old and frail and a child that's 10 years old, we're talking about 10,000-fold or more differences in risk. In my life as an epidemiologist, I have been working with risk factors of 1.3. In the last decade, I have been working mostly with risk factors of 1.03. We know also that not only age, but also underlying diseases are making a huge difference. Across different countries, very early on in the pandemic, even in the first wave where we just didn't know what exactly to do, we realized that if you look at people less than 65 and those who have no underlying diseases, the proportion of deaths represented by that majority of the population is tiny. In the range, for example, of Italy, which is closest to Austria, of 0.7%. I think Austria is about the same range. These are data comparing US, Italy, Portugal, Switzerland, and Netherlands, comparing the overall mortality rate and also the mortality in children and the mortality in young adults. You see the tremendous difference that exists. Mortality in children per million, we're talking about something like 0.37 per million in the Netherlands, the highest being in Sweden and US, 4 to 5 per million. And in young adults, we're talking something like 2.9 per million in Switzerland, all the way to 40 per million in the US. So basically, we have a very peculiar situation. We have a disease that is tremendously lethal for very small segments of the population, which are shown here in their representation in a typical European country, the slices with the thick color, and is relatively sparing the large majority of the population, the slices that do not appear with dark color. The most vulnerable is the nursing home population, where many European countries and the US face major massacres with anywhere between 30 to 70, 80% of the deaths occurring in nursing homes in the first wave and doing a bit better in the second wave. Basically, if you see red color, that means huge overcounting. If you see orange color, that means substantial overcounting. Conversely, if you see that gray, that means undercounting. Most combinations suggest overcounting of COVID-19 deaths. But there's clearly differences across countries. For example, in Europe, I would argue in most Western European countries, the most likely scenario is that COVID-19 deaths have been overcounted. Infection fatality rate. What is the chance of dying if someone gets infected? This is a paper that I published about a year ago in the bulletin of the WHO. It collected the data from all the available seroprevalence studies done until that time that were close to a general representative population. And on average, the median across 51 locations was 0.23%, which was much lower compared to our expectations in the beginning of the pandemic. There are other evaluations that have tried to do the same. Some of them, most of them, pretty much agree with these numbers. A couple of them, like the one from Imperial College, suggest higher infection fatality rate estimates. But as I show in that paper that was published 4 years ago, I think that they have tremendous biases. It's a paper 37 pages long, and you can take a look at all the biases that I think exist in these calculations. My best estimate for a global infection fatality rate at the moment is in the range of 0.15%. For Europe and Americas, it's higher. On average, 0.3 to 0.4%. In some countries, it's higher than others. In some time periods, it's higher than others. For community-dwelling people, it's about 0.2%. Because as I said, we had a very huge contribution of deaths in nursing homes. See that all of these estimates pretty much agree up to about 50 years old, that this is very low. Where we disagree is at the higher age strata. Our estimates, and these estimates agree with O'Driscoll mostly, suggest much lower estimates of infection fatality rate in the elderly strata, without that meaning that the elderly do not really carry the large burden of the disease. If a country or a location gets mostly blasted in its nursing homes and its vulnerable elderly people, the infection fatality rate will be astronomical. But that's very misleading in terms of what's happening to the rest of the population. When vaccines became available, most countries did prioritize those who were more vulnerable. Why? Because it was so obvious. But before having vaccines, many people said, oh, we cannot really protect, we don't know, we just, everyone just the same, just lock everyone in their bathroom and not let them get out. And I thought that that was completely silly because we were ignoring risk ratios of 10,000. The US, New York, and also most of northeastern states in the US also had high infection fatality rate in the first wave. Not surprising, the governors sent COVID-19 patients to nursing homes. So we just did exactly the opposite of what we had to do. We closed young people, told them you cannot study, you cannot see your mates, you just shut yourself in, and we sent COVID-19 patients to nursing homes so that everyone can be infected and die. It's just completely mind-blowing. Compared to Sweden and South Korea, that didn't have the draconian components, the other countries did not do any better. Actually, they tended to do worse. countries that had the most draconian restrictive measures compared to those who had some measures that were restrictive but not the draconian version, the draconian ones did worse. Deaths from poverty and starvation. 9 million people die every year from starvation. And this includes 3.1 million young children. One child less than 5 years old dies every 10 seconds. So now we ask countries that have this problem to lock down. And people cannot get out, they cannot work, they cannot get food. And they're starving. And we're saving lives, or so we think. According to Oxfam, 619 million people in 2020 faced food insecurity, of which 135 million were in severe stage of hunger, and this number may have doubled to 270 million with the pandemic and the measures that were taken. According to the World Labour Organization, 305 million full-time jobs were lost due to the pandemic and measures taken, pushing an extra 500 million people to or below the poverty levels. You can add to that the consequences of climate change, of war, of instability in many heavily affected countries, and you can see a real disaster that is much, much bigger compared to what COVID-19 could have done. Smoking. This is really what I have to scream. We have almost 10 million deaths from smoking every year. Maybe a bit less, but it's going up. And we are estimating 1 billion deaths in the next century unless we do something. Half of them are people who are less than 70 years old. They're not really old people. And for a smoker, the chance of dying from smoking is estimated at 2/3. 2 out of 3 smokers will die because of smoking. Half of COVID-19 deaths may be due to underlying diseases due to smoking, in fact. So do you want to count them as COVID-19? I count them as smoking, actually. I'm biased perhaps, but this is what I count them. As you know, tuberculosis is killing 1.5 mostly mid-age and young people every year. And actually the measures that we have taken are going to increase by another 1.5 million the number of deaths just because of the restrictive lockdowns that we have implemented. Most people faced mental health problems during the pandemic. We have multiple surveys around the world that suggest we had doubling and tripling of the rate of mental health problems during the pandemic. And same thing for anxiety, same thing for depression. Some countries did a bit better, others did worse, but overall we had a major, major problem. We have solid evidence that 0.1% of the population died with or from COVID, probably mostly with COVID, and 50% of the population just got nuts. Just compare the numbers. They're multiple log scales off. Education, lost years and lost lives. 90% of students around the world had their education disrupted. Data from the Netherlands, that is a country that has the best infrastructure, the best connectivity, can have laptops and infrastructure for practically almost all students to be able to continue by Zoom or from a distance their quote-unquote learning, showed that during the lockdown students learned next to nothing. Actually, the poorer students regressed 60% more than wealthy students. It was a wonderful way to create more opportunities for the wealthy and for the privileged, and to destroy those who were disadvantaged. And in the US, it was not just education. These children had to go there to get food to live. So it was a massacre. I think it was a public health blunder of the top magnitude, probably the worst in the last century. According to UNESCO, 24 million students, including 8 million studying in universities, will not be able to return to their studies after the pandemic. In the United States of America, according to a study by Christakis that got completely attacked, more than 5 million lost person years from closed schools in the US in the first wave occurred, which is far more than the loss of life from coronavirus. Could the study be wrong? Could it have flaws? Every study has flaws. Can we correct that by 5-fold? Yes, maybe, who knows? Even then, it is a tremendous burden, and it cannot be compared with any benefit that we would get. What exactly do you mean by zero COVID? Now, I love zero COVID. I love zero cancer, I love zero tuberculosis, I love zero starvation, I love zero any disease. But the question is, can we achieve it? And will efforts to achieve it reduce or increase SARS-CoV-2 deaths as well as overall deaths and burden of total, not just SARS-CoV-2 related disease? Can we get rid of the virus completely? Well, we have to ask, how many other diseases have we managed to eradicate entirely? You can think of smallpox, but how about tuberculosis? How about malaria? How about syphilis, yaws, diseases with animal reservoir, with many subclinical infections, with many asymptomatic infections like COVID-19? Can't think really of situations like that. Is zero COVID-19 also up to us, or is it up to the virus? Maybe the virus will decide to disappear. I hope he does, but I don't really think so. And is it up to us whether SARS-CoV-2 eventually will become, or already is, endemic, and what its severity and total burden will be in future seasons? Most scientists believe that this coronavirus will become endemic, and this is a slide that is a few months old. I think it has become endemic. If we have 2.5, who knows, 3 million, maybe more infections already, isn't that endemicity, practically? What does this mean to be endemic if we can protect the elderly through vaccination, for example, and the vulnerable? It means that SARS-CoV-2, according to the science paper, may be no more virulent than the common flu. Let me translate that for you. Could we reach a point where we wish that this next year will be one with COVID-19 rather than influenza. Ideally, of course, we want nobody to be infected. However, if people are infected, 40 to 70% of the global population would do better if infected with SARS-CoV-2 than with influenza. With better treatments, this percentage may rise to 60 to 80%. So the question is, what do we do with this 20 to 40% that can be at high or even astronomically high risk? If we can largely effectively shield them with vaccination or with other means, the infection fatality rate of SARS-CoV-2 may become far, far lower than the infection fatality rate of influenza. And in this case, it sounds like a paradox. We might even celebrate if in a given year we have what is going to be this year. It's not influenza, it's going to be SARS-CoV-2. Oh, that's wonderful.